Okay, welcome to the second topic, the second lecture series on Physiology 2. This is Physiology of the Endocrine System. Today we're going to be talking about the hypothalamus and the pituitary gland. These are going to be kind of a big focus, not only for this class, but also for future courses. A huge chunk of the whole first chunk of material in your one of your other systems pathology courses is going to involve a lot of this, as well as a lot of the hormones and stuff that we're going to talk about with these two structures are going to be kind of integrated into a lot of the different conditions and diseases that we're going to see, especially ones that can affect how we as chiropractors go about treating patients. So we're going to want to make sure that we focus on these. We know these. We know the signs. We understand this whole sort of process, especially in today's world, as we've talked about. Hormones really play a much bigger role in our homeostasis, especially in today's age when a lot of the food and the material and the stuff that we consume in our bodies and the things that we have in our environment are more prone to disrupting our hormone balance. So this is something that's really, really cool. If you have time or in the future as you go into practice, kind of dabbling into this world and finding a very good person to refer to with patients who you suspect might have hormonal imbalances is a really, really cool thing. As well, there are chiropractors out there who do the full written up lab work of all the hormones, and that's part of the service that they provide in office. So whether you agree with that or not, if that's under your scope of practice, depending on where you practice, I mean, it's kind of up to you. So learning objectives. There's 4 of them today, but these kind of cover a lot of space, a lot of material. So first of all, we want to discuss the role of the hypothalamus in the control of the endocrine system. We're going to talk a lot about tropic hormones. Tropic meaning change. So, these hormones are really going to be kind of one of the central control mechanisms to get stuff out to the rest of the body. We're going to look a lot at like the feedback loops and that kind of stuff as well towards the end. Next, list the hormones produced by both the anterior pituitary, posterior pituitary, and how the secretion of each is controlled. Again, we'll look at a lot of those loops. The action of growth hormone and the results of dysfunction of this hormone. This is a really, really big one. This comes back a lot in many different courses, so we'll take our time on that one as well. Finally, ADH and oxytocin and the effects of dysfunction of these hormones, kind of how they work and what their dysfunctions look like. So just another little picture. We're focusing on the hypothalamus and the pituitary. As we can see with the pituitary gland, there are lots and lots of hormones from the pituitary gland. All of these guys, as well as the posterior lobe, production, as well as the regulatory hormones. Hypothalamus is kind of like the regulator, and pituitary gland is more the distributor of these hormones, and we'll get into that. So the hypothalamus itself. So the hypothalamus secretes the tropic hormones. Tropic, you can think about the word like atropic or trophic, like atrophy, hypertrophy. It means change. So the kind of the tropic hormones, they're the ones going to be released and affect other glands. The hypothalamus itself is an endocrine organ, but there's also a neural control which connects the hypothalamus to the adrenal gland and as well to the posterior pituitary gland. We'll get more into detail of this stuff. It's just kind of the general stuff. Understand the hypothalamus is kind of the master control endocrine gland. Okay, it's in charge of really making sure that everything gets released in the proper amount, that it's checking the concentration of all the different hormones in the blood, making sure, fine-tuning our levels to make sure we don't have too much or too little of anything going around in our systems. I added this in here mostly because with the adrenal gland, we're going to have a whole unit and a whole chunk focusing on the adrenal gland, but this is something that is heavily tested on in like exams, in board exams in the future as well. This kind of stuff, they love these questions with all, the different zones, the types of hormones, and the names of those hormones. So this is something I would recommend, even right from the gun. Start by making, a Quizlet with all of these in there in order to give yourself ample time to start learning all of these different chunks. And you should have seen this as well in, I believe it was in Gross Anatomy 1. If it wasn't Gross Anatomy 1, you will see it again in Gross Anatomy 2. Your anatomy courses, as well as I believe some of biology of cells and tissues, should have covered some of this. So make sure you continue to understand this, as again, this will not go away either. Okay, the pituitary gland. We have lots of AKAs for stuff. So the pituitary gland is AKA our hypophysis. Okay? And there are going to be two components of our hypophysis. So the hypothalamus is above. We have this little connection called the infundibulum. We have an anterior lobe and a posterior lobe of the pituitary gland. As well, there's some more kind of division within there. So the anterior pituitary, also known as our adenohypophysis, and then our posterior pituitary, also known as our neurohypophysis. That has to do kind of with embryology, which we'll get into. We'll just touch on that so you can understand the basics of why it is what it is. So our anterior pituitary gland is made up of two different parts. There's one part, when we get into like the cell structure of things, we have a pars distalis and a pars intermedia. Both of those components are part of the anterior pituitary. The posterior lobe, aka that neurohypophysis, is made up of cells, and we call that the pars nervosa. So all of these different terms can be used for examination. So if you see anterior pituitary, you need to know that that is also your adenohypophysis, or you could also technically call it your pars distalis or your pars intermedia, more commonly your pars distalis. And then the posterior pituitary can also be called the neurohypophysis or the pars nervosa, or you could even call it the anterior and posterior lobes of the pituitary gland. Here's all the names. I wrote them all out for you. Anterior pituitary, all the AKAs, the posterior pituitary, some of those AKAs that you can have for it. So here's the embryonic development of the pituitary gland. I went ahead and I spelled it out completely for you, kind of the whole step-by-step development of all of these. But really what we want to remember is that the anterior pituitary gland comes from an embryonic structure called Rathke's pouch, which is from the oral ectoderm. You'll cover more of the ectoderm, mesoderm, all that kind of stuff when you dive into your neuroanatomy and your clinical neurology courses. Also, if you're studying for boards, there's a spinal anatomy section, which will dive into all of the different parts of this, of the ectoderm, the mesoderm, and all of those kind of embryological structures. Well, we want to associate the anterior pituitary with Rathke's pouch, the posterior pituitary with the neuroectoderm, from what's another structure, an embryonic structure called the diencephalon. This is more just kind of the anatomy. This picture, you have that infundibulum, that anterior pituitary part of it. Now, kind of getting to our actual first question of the role of the hypothalamus in the control of the endocrine system. There is a clear connection between the hypothalamus and the pituitary gland. There are special vessels as well as special neurons which connect these structures. So we can look here in this picture in the hypothalamus. We have a couple of these different nuclei, and they come down with direct connections to the posterior pituitary. So our neuronal control primarily goes to the posterior pituitary, and we also have that direct control to the adrenal gland. Okay, that's the neural control. Add neural control over adrenal medulla and posterior pituitary. Those are the ones we want to remember with neural connection. We also have a vascular connection. So see all of these veins and structures that are going right here that connect the hypothalamus to the pituitary gland. And this is how the hypothalamus primarily communicates with the pituitary gland. Okay? As we know, hormones are part of the endocrine system. The endocrine system is that internal system, and it travels through the bloodstream. So it's through the bloodstream that these hormones are able to travel, and they interact with the receptor sites. So we're sending hormones from the hypothalamus really close by to the pituitary gland in order for then the pituitary gland to release hormones, and we'll get deep into all of that a little bit later. And again, I have deeper dive into all of the anatomy, the hormones, all that kind of stuff that gets in through there. This is all extra material. This isn't stuff you have to memorize, but it helps you understand the different structures if you want to read that. And again, if you want to get any of my notes, there's a link in the description below where you can get access to all of them. Okay. All the blood that's entering the portal system is going to reach the intended target cells before returning to the general circulation. Because it's so close, it's right there. Okay, so we're going to look at a broad view, and then we'll dial it in a little bit. So these are all of the different hormones that the hypothalamus are going to release to act on the hypophysis. Hypophysis, again, is that fancy word for the pituitary gland. You can look here, all the different types of hormones. Again, pretty much all of them. A lot of them you'll see that tropin, growth hormone. I believe the technical proper name of is human growth hormone is also known as somatotropin. Let me add that in here. Growth hormone equals somatotropin. So then that would be a somatotropin releasing hormone. Or somatotropin releasing hormone would be another way that you could say that as well. Add somatotropin. There. Okay. It's going to give you all of the different actions of everything that's released. We're going to look at each of these kind of individually, not necessarily in depth today, but throughout this course, we're going to look at a lot of those. Almost this entire course is the endocrine system, or some component of the endocrine system, where we're going to be doing a deep dive into each different kind of system, as well as the stuff that can go right or wrong within those systems. So I'll briefly touch on each of these, kind of the rough general way that they work today, but then we'll dive into each individual one later on. Here's just another little anatomical map of the hypothalamus with all the different nuclei that are inside of it. Again, nuclei just referring to a grouping of specific cells that do specific or similar type functions. So we have the periventricular nucleus, both of these here. We have the anterior, I believe if I'm not mistaken, this is the anterior, this is the posterior periventricular nucleus, as well as the arcuate nucleus that are responsible for some of these, the release, or the production and the release of these specific hormones. Okay. Here's a nice little chart, kind of the flow of all these hormones, where you see each of these different releasing hormones going to affect the specific spots in the pituitary gland, the anterior or the posterior pituitary gland. And we'll get more into all of this. This is just like the rough overview map. This is a really good one that you can kind of pull from and study from. Okay, right now we're going to focus on the anterior pituitary. So again, the adrenal hypophysis is the anterior pituitary gland. And that is going to secrete 6 individual hormones. And here they are. We have the cell type, the specific hormones, 1, 2, 3, 4, 5, and 6 hormones, and their functions. Don't give too much concern to the chemistry. If your professor wants you to know the actual chemistry of them, they will let you know. Typically, this isn't one to worry that much about, but it's good information to have. So we're going to keep on going. There's just that little definition, that tropic, where that comes from to cause change. So all of these hormones, the ones we're going to look at: adrenocorticotropic hormone, ACTH, thyroid-stimulating hormone, follicle-stimulating hormone, luteinizing hormone, prolactin, and growth hormone, aka somatotropin. Here's just another picture, kind of reiterating. Okay, remember up in that hypothalamus, there's that direct neural control to the adrenal gland, as well as to part of the posterior pituitary gland. I'm going to add that in there. Let's do a little black line. Make it pretty thin as well. There's also connection there. And I'll get into the specifics of that connection later on. Okay, so this, you can see, this gives you, again, another general overview of the different hormones from the hypothalamus. So these ones are coming from the hypothalamus, then to the anterior pituitary, and then what hormones come off and where they go to interact with their different target organs. This is the general chart that we are going to look at. So this is the control mechanism. You'll see this also known as feedback mechanisms. I don't like when everything is... This says hypothalamo-hypophyseal control mechanism. So hypothalamus, pituitary gland, control mechanisms. This is the general structure, and I have all these available at the very end of the PowerPoint for you to look at. This is the big money of like, hey, this is what we want to understand, okay? If we can understand this right here, the flow of hypothalamus, what is released from the hypothalamus that either activates or inhibits the anterior pituitary to release another hormone to go to the target gland, to that goes into the blood, which then we can then identify and process and either turn off or on the hypothalamus, releasing that hormone again. Okay, this is going to be the either positive, pushing things forward, or negative feedback mechanism. This is where a lot of your kind of test questions, general understanding, as well as pathology, understanding the pathology, is going to really come from. That's just a repeat of the same picture. Don't know why that's there. Okay, we're going to dive into some of the specific ones. So first off, growth hormone, aka somatotropin. And just like its name, it is responsible for growth and metabolism. I'm going to find the specific. Here we go. Here's our feedback mechanism for our growth hormone. It, of course, starts with, we need a hormone released from the hypothalamus. So the hypothalamus is going to release growth hormone releasing hormone, and it goes to the pituitary gland. The pituitary gland releases growth hormone, and later on we'll go into a little bit more detail, about this exact whole process, but growth hormone goes and acts on a bunch of different parts of the body, and just like it says, when it binds to it, it causes the body to grow. Let's go back to where we were. Okay, again, that AKA for growth hormone is somatotropin. It is a water-soluble hormone. So here, the growth-producing effects of growth hormone. So you can see our body, we grow, and your body keeps a really good control of our growth. This is somebody being injected daily with growth hormone. So this kind of shows, again, with the graph, if our body is not controlling our growth hormone well, we can also have some other effects with growth hormone. So the effects of the mechanism of action of growth hormone is it has a direct effect via a receptor binding and then a second messenger system. So there's two different ways that it has its effects. Actually, direct. I don't want to get too specific into the names of everything. So the growth hormone binds to growth hormone specific receptors on target cells, which stimulates the production and secretion of IGF-1. So that's actually specific more to the liver. So growth hormone is going to bind to the growth hormone specific receptors on the different target cells. So if it's going to go and it's going to bind to different components, different parts of the body. Let me actually pull up. I believe it has it in here. So the growth hormone is literally going to go and it's going to bind like that direct. You're going to see it's going to bind to muscle, to bone, as well as adipose tissue. I think it's actually later on. Yeah, it's down here and all through there. Okay. But then we also have an indirect method of growth hormone activating. So indirectly, it can go and it can bind in the liver. And by binding in the liver, you get the production of IGF-1. And that I should have written it down right here. It's an insulin-like growth factor 1. They call it insulin-like because the way that it binds is similar, the way this receptor works is similar to insulin. It is also known as somatomedin C. Okay, this wording is one of the ways they love to ask about this question. So in the liver produces somatomedin C, giving us insulin-like growth factor. So growth hormone goes, it binds to the growth hormone receptors in the liver, and it produces the IGF-1, aka somatomedin C, which then allows our body to perform the growth and stuff that it needs to. This is an example. There's usually a video that a lot of professors like to show with this. This is a pygmy tribe in Africa. Essentially, this whole group of people have an issue where they're actually missing somatomedin C, as well as like their growth hormones themselves. The receptors, they have a lower level of receptors of the growth hormones, and because of that, they just don't grow nearly as tall as you would expect from quote unquote the normal or typical individual. So here we can see kind of some of the different general effects. So growth hormone and bone growth. So it binds to on the chondrocytes. The chondrocytes are cartilage cells and causes them to proliferate, to divide, to grow, and to continue to lay down collagen. to help to grow the long bones. It also causes the osteoblast proliferation, creation of more osteoblasts, and converting the chondrocytes into osteoblasts as we form our bones. So basically, bottom line, growth hormones makes bone grow. Now the metabolism, lots of questions like to come from growth hormone and metabolism. So we get increased protein synthesis, so we make more proteins because we need to have the proteins, everything available to build and to create the structures and stuff that we need in order to do the jobs that we need. As we build and grow the muscle, as we grow the bone, as we grow all these other things. Lipolysis favored in beta oxidation, so it stimulates the hormone-sensitive lipase. So actually this is going to go to the adipocytes, so tells the adipocytes to let go of more fat to use as energy as we grow. So this is why typically when you think about somebody who goes through a growth spurt, somebody might be, a chubby or a slightly overweight again, young teenager or older kid, so around that like 10, 11, 12 kind of age, and as soon as they hit puberty, when growth hormone really kind of floods our system, suddenly, they'll lean down and they'll grow a bunch. So that's part of that. That's because of growth hormone, because the growth hormone is going to favor lipolysis and beta oxidation, so using the fat as energy. So growth hormone and the carbohydrate metabolism, so it's going to conserve the carbohydrates, so it's going to use more of the fats, so we don't uptake as much of the carbohydrates, so we need less insulin, and we just have diabetogenic, kind of meaning, you can, it's kind of that connection to, if you have some stuff off with growth hormone, you can start to see some of these effects. So it's similar to like diabetes, where the muscles will take up less glucose, you'll increase lipolysis, you'll increase gluconeogenesis, you'll increase glycogenolysis, storing of the glucose. And then muscle, liver, and fat are more insulin resistant. Here's all three here. So human growth hormone goes directly to adipose tissue, goes directly to muscle, goes directly to the liver. And you go and you get the IGFs, and it goes to the bone, the heart, the lungs, and to the chondrocytes. So this right here, this would be our direct, so the adipose tissue, liver, and muscle. I'm going to correct myself back here. It was this slide. Directly to liver, adipocytes, and is it muscle? I believe was the other one. Yes, muscle. Adipocytes and muscle. Okay, so directly it binds to liver, adipocytes, and the muscle. Indirectly, it's going to go to a bunch of the other structures, like the bone, heart, the lungs, and the chondrocytes. And you can see all of the stuff that it does. What you'll be asked as far as questions, you'll be asked this in general. You'll be asked a lot about kind of glucose and insulin type factors. So when we get an increasing growth hormone secretion, that decreases the blood glucose, it decreases the blood fatty acid. It's more of a starvation, fasting, protein deficiency type environment. We increase our testosterone and estrogen, like in puberty. You can tend to get deeper sleep. And the growth hormone releasing hormone, I think that's a error. Okay, that's correct. Yeah, growth hormone releasing hormone, also known as somatocrinin, is being released. decrease of, I should say, my bad, all of these things are going to increase growth hormone secretion. So when we have decreased blood glucose, we'll increase growth hormone secretion. If we have decreased blood fatty acids, we'll increase it. Starvation, fasting, or protein deficiency increases the growth hormone secretion. With stress and trauma, we increase the growth hormone secretion. With exercise, it increases it. Deep sleep increases. This is why sleep is so important. Testosterone and estrogen lead to increased growth hormone secretion. And then on the other side of this, all of these will decrease the growth hormone secretion, or at least are connected to a decrease in growth hormone secretion. This chart is a little bit confusing. Spend a little bit of time kind of walking through this and understanding what's going on. So understand, with an increase, growth hormone secretion will happen due to all of these down here. A decrease in growth hormone secretion will be due, or is connected to, all of these down here. GHIH is the growth hormone inhibiting hormone. There's the regulation of secretion, which is just this chart again, just in picture form, where we see stress, fasting, exercise, and sleep will have an effect depending on where we are in that whole depending on where we are, whether we're high stress, low stress, fasting or non, exercising a lot or a little. If we're sleeping very little or we're getting deep sleep, will determine whether or not we're activating human growth hormone or inhibiting it. So we can see here the different releases. So with sleep, deep sleep, with strenuous exercise, kind of stuff. Now, talking about growth hormone, either too much or too little. There's a lot of little technicalities with talking about growth hormone and whether there's too much or too little. So, if there is not enough growth hormone, especially when you are in your time where your growth plates are open, so before you finish going through puberty, not having enough growth hormone produces pituitary dwarfism. So this individual, very, very small. So dwarfism tends to be not enough. So we can say that is tropism. If you have too much growth hormone, so you are releasing way too much growth hormone before your growth plates are closed, this leads to gigantism. Okay, so essentially your body grows and grows and grows without stopping because your growth plates are still open and you can continue to grow. After skeletal maturity, so after fusion, by fusion it's referring to skeletal maturity. That produces a condition called acromegaly. If you remember, prominent figure that you'll see, let's see, if you've ever seen The Princess Bride, bam, Andre the Giant. He is a very well-known individual who has had acromegaly. So basically, once the growth plates are closed, the bone isn't able to continue to grow lengthwise. Instead, it grows in thickness. So you get a thickening of the features, especially like a really big, kind of almost like a caveman-style forehead, and also an increase in the jaw bones due to growth hormone oversecretion. So the effects of protein deficiency on growth hormone production. So when we're deficient in proteins, deficient in protein, we tend to have higher growth hormone levels. Now, so big things you want to remember from this: acromegaly, too much growth hormone after the growth plates have been closed; gigantism, too much growth hormone before the growth plates close; dwarfism, not enough growth hormone when the growth plates are then close. Getting into the posterior pituitary, aka the neurohypophysis. This one's a little bit similar. There's not as much stuff to go through with this one. So we have two that we're going to see. We're going to see ADH, antidiuretic hormone, and oxytocin. This is a big, I put this in highlighted and bolded because it's really important. It's always tested on by teachers because it's the only example of it. So ADH and oxytocin are produced, so they're made in the hypothalamus, and then they are then transported into the posterior pituitary, and then are stored in the posterior pituitary. So be careful when you're answering questions. Make sure you watch and say, is it asking where these are produced, or is it asking where they are stored or released from? So they are stored and released from the posterior pituitary, but they are produced in the hypothalamus. So first, our antidiuretic hormone. Let's go over the process of it. So within the hypothalamus, you have these osmoreceptors. ADH, antidiuretic hormone, is responsible for water retention, making sure that our the osmolarity, the concentration of our blood, is kept at the optimal rate. So that way, like our viscosity, our blood pressure, all that kind of stuff is maintained. So in the hypothalamus, it's constantly checking that concentration, and it has a direct nerve signal to the posterior pituitary. If our concentration is too low, meaning that we have too much water in our system, we decrease the amount of ADH that we are releasing. So we decrease ADH overall, which means our body doesn't hold on to as much water, so then we release more water. More water gets filtered out by the kidneys. If the concentration is too high, that means we don't have enough water, and so we're going to increase ADH release, which is going to tell the kidneys, hey, we don't have enough water. When you're filtering, make sure you reabsorb that water, take that water back in, as well as it's going to stimulate our thirst reflex. So ADH is going to make us feel thirsty. Another AKA, a name for antidiuretic hormone, is vasopressin, because it's also going to have an effect on the blood vessels. ADH is going to go and it's going to bind to the blood vessels and cause constriction, because if you think if we don't have enough fluid in the blood, our blood pressure might be a little bit low, so it's going to cause constriction in order to increase the blood pressure and keep the blood moving. In the kidney, we're going to have increased water reabsorption, and the secretion, we already talked about this, is stimulated by an increase in the plasma osmolarity, thanks to those osmoreceptors in the hypothalamus. Now, too much or too little ADH. Diabetes insipidus means that we don't have enough ADH. Essentially, our body's not producing or not releasing the ADH for whatever reason. This causes us to lose a lot of water. So we have two different types. It can be neurogenic, meaning it's from the brain, from the nervous system, or nephrogenic, meaning that it's due to the kidneys. I'm going to add these up in here so that way it's easier to see. Okay. So the neurogenic is due to injury, dysfunction of the hypothalamus or the pituitary gland itself, due to any of these reasons, and that causes not enough release of ADH, and therefore we get large volumes of diluted urine or polyuria. Nephrogenic, it's a disorder involving urine output. Essentially, your body doesn't respond properly to the vasopressin. So this is often because of the kidneys themselves are injured or damaged, and those receptors are no longer there to be able to do their job. Now, the opposite side of the coin SIADH, this is syndrome inappropriate ADH. This is excessive or a hypersecretion of ADH. So think if ADH's job, is to pull back in the water, you can imagine essentially we're pulling in and keeping way more water than we're supposed to. So you get something that's called hyponatremia. That is a low sodium concentration due to excess total body water. Our body's holding on to way more water than it's supposed to. Some of the causes are conditions like small cell lung carcinoma, meningitis, brain tumors, or the drug ecstasy. And you'll go more in depth to each of these why in systems pathology courses in the future. Now, oxytocin. This is the super unique one in the reason why is because this is one of the only feed-forward reflexes or feed-forward loops that we are going to see. So the job of oxytocin, it does two different jobs. It's to help with childbirth and also help with milk letdown. So it stimulates the letdown reflex in lactating mothers, so stimulated by the suckling of the baby. So this, tells the milk from the cells to go down into the lactiferous sinus in order for the baby to feed. As well, oxytocin is released during childbirth. So when you have distension of the cervix and the uterus during labor, this causes a feed-forward loop, which causes more contractions and more dilation of the cervix and so on. So this says contraction of myometrium to promote parturition. So in English, this means oxytocin release causes increased contractions to move the birthing along, or to help induce the birthing process. You also get increased cervical dilation to help the baby come through. So right here, this is almost always a test question because it's one of the only examples of this feed forward mechanism. So teachers tend to really like this as a question because it's very, very easy to tell, who knows the answer and who doesn't, because it's the only one of its kind. So the baby takes up all the space in the uterus. Baby starts to send the stretch receptors, activating the uterus. The brain signals for release of oxytocin. Oxytocin causes uterine muscles to contract. This is also why breastfeeding immediately after giving birth, you want that skin-to-skin contact immediately going from birthing to breastfeeding, helps the retraction and the contraction of the uterus faster, because with breastfeeding you get a sudden surge of oxytocin as well to help the uterus finish contracting back down to close to its original shape. Additionally, oxytocin here's a couple different studies for oxytocin, some of the other stuff that we talk about with it. Oxytocin also helps with bonding and creating connection with the baby. So these last slides, these are all ones that I have added. This is just going over this is just the examples of those feedback inhibition graphs. Like I said, these are the ones that you really, really, really want to know. So the hypothalamus releases thyroid-releasing hormone, goes to the pituitary gland. The pituitary gland releases thyroid-stimulating hormone, which goes to the thyroid, and then causes the thyroid to release T3 or T4. And then once that's in the blood, remember the hypothalamus is, registering what's in the blood. It's checking what's in the blood, so it sees, oh hey, we have a good concentration of T3, T4. We no longer need to be stimulating this, so hypothalamus cuts it off, or the pituitary realizes and it cuts it off. This is where then you start to get into a little bit more of the lab work and a little bit more into some other conditions and what can go wrong. So for example, let's say we have a tumor of the pituitary gland, and the pituitary gland is producing thyroid stimulating hormone without any TRH. So let me give you an example. So pituitary tumor. So with a pituitary tumor, we make a bunch of TSH. And what's that going to do? That's going to cause high T3 and T4 levels. So this T3, T4 is coming back, to the hypothalamus and telling the hypothalamus, hey, shut off. We don't need more T3, T4. But the hypothalamus already isn't releasing any thyroid-releasing hormone. It's just the pituitary gland doing it all on its own. So if we were to look at the lab values of a pituitary tumor, we have high TSH, high T3, T4, and T4, and low TRH. That's a pituitary tumor. I'm going to put that down in the notes below. What about if the thyroid is the issue? What about a thyroid tumor? So let's see, because of the thyroid tumor, the thyroid is the issue. We have a bunch of T3, T4 being released with no TSH or TRH being released. So we look at the lab values, high T3, T4, low TSH, low TRH. We say, okay, this is what we can identify, if there's a thyroid issue, this is where the issue is. If there's a pituitary tumor, then this is what the lab values should look like. But what if we have like another condition? Like let's say we have low T3, T4. We have an autoimmune condition. Our Hashimoto's thyroiditis, right? We have our body's attacking the thyroid gland and breaking it down. So we have low T3, T4, but because we have low T3, T4, the thyroid is the issue. What's happening before that? The pituitary gland and the hypothalamus both are working just fine. So the hypothalamus is saying, hey, we don't have any T3, T4, so it's releasing thyroid-releasing hormone. And the pituitary gland is receiving that signal and saying, hey, we don't have any thyroid hormone, so it releases thyroid-stimulating hormone. But because the thyroid itself is not working, we don't get any release of T3, T4. So we can see, and you'll see this more in either Tri4 or Tri5, depending which program, if you're in the regular blended. When you start to look at lab values, and you'll have a lot of questions based on this. This kind of preps you for your lab diagnostic course. You can tell, hey, where actually is the issue? Is the issue in the hypothalamus? Is the issue in the pituitary? Is the issue in the thyroid? And so on and so forth. And then you can make a diagnosis off of that. Here, I'm not going to go detail of each of these because we're going to see all of these later on. Here's in the male, the gonadotropin-releasing hormone. And then in the female, the corticotropin-releasing hormone. When we'll look at the adrenal glands as well. Growth hormone-releasing hormone. This is the one that we looked at today. So this one, make sure you come back and review this guy. And then we'll also look at, we don't talk about this one a lot, the prolactin inhibiting hormone. But when we get to a little bit more of like the reproduction system towards the end of the unit, that's when we'll kind of touch on this guy. Okay, this video was a little bit longer, but it was a lot of really, really good information. So like I said, if you want the notes, if you want access to these materials, please go ahead and look in the description below. There's a link in order to get access to all of those. Thank you, everybody, and have a wonderful day.